Cutaneous squamous cell carcinoma is usually treated effectively, but the words in the pathology report, the tumor site, and the patient's immune status determine whether the next step is routine or more urgent.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Section 1. Understanding the diagnosis. Now, before we start categorizing urgency or risk, what exactly do these complicated pathology terms mean for you if you're just looking at a concerning spot on your skin? How do we even know what we're dealing with?
Well, let's look at the labels because they are definitely not interchangeable. Cutaneous squamous cell carcinoma, or CSCC for short, is a cancer that begins in the squamous cells of the skin's outer layer, the epidermis. We literally have to separate three very different diagnoses here: actinic keratosis, SCC in situ, and invasive CSCC. And actinic keratosis is a UV-related lesion, sure, but it is not the same diagnosis as invasive CSCC. SCC in situ means an abnormal cells involve the epidermis, but they haven't crossed deeper. And then there's invasive CSCC, which has a completely different treatment menu.
Here's the golden rule to remember. In situ describes a boundary. The abnormal cells are confined right in place. Invasive, on the other hand, means those abnormal squamous cells have actually crossed that basement membrane boundary beneath the epidermis and entered the deeper skin. That ability to invade the deeper tissue is exactly what makes it a cancer rather than just a surface change.
Section 2. The biopsy margin trap. So the critical difference is whether those cells crossed the boundary. But how does a doctor actually figure that out?
If you have a persistent, growing, bleeding, or painful crusted spot, can you just snap a quick photo from your phone and send it in to see if it's invasive?
The short answer is no. A photo can absolutely show a reason to look closer, but it cannot diagnose microscopic invasion. A biopsy is strictly required to establish the exact diagnosis. But here's the trap you need to watch out for. A diagnostic biopsy is just a sample. It simply answers the question, what is it? If the pathology report says the margins are negative on that diagnostic biopsy, it merely means tumor was not seen at the examined edges of that specific sample. That alone cannot prove that the whole clinical tumor left on the patient's skin has been cleared. Definitive management must answer a second, absolutely crucial question: has the clinical tumor been adequately cleared?
Okay, let's hit pause and reset for a second. A biopsy confirms we have an invasive cutaneous squamous cell carcinoma. The boundary was crossed. But for the patient actually sitting in the clinic, how do they assess their true danger level? How do we know how bad it actually is?
Section 3. Risk is not spread. The answer lies in risk stratification. We have to look at the whole risk picture because your prognosis completely depends on it. The most important question isn't just, is this SCC? It is, which SCC is this?
We categorize these tumors into lower risk, high risk, and very high risk pathways based on features like site, size, depth, and exactly how the cells look under a microscope. Crucially, a high risk or very high risk label means there is a higher probability of an adverse outcome, and the local or regional plan needs to be much more intensive. But we must be absolutely clear here. A high-risk label does not prove that metastasis has already occurred in a lymph node or another organ. Risk is not the same as spread.
To understand why getting this category right literally dictates the entire treatment plan, look at the Stevens cohort data from 2 U.S. referral centers. They looked at over 10,000 treated primary tumors. For lower-risk tumors, the 5-year cumulative incidence of local recurrence was just 0.8%. But for very high-risk tumors, that recurrence rate jumped to 9.4%. Nodal metastases and CSCC-specific death also showed markedly different outcome patterns across these risk groups. You just cannot use one pooled percentage to describe every tumor.
Section 4. Immune status and symptoms. If the physical size and depth of the tumor define the risk, what other hidden factors could unexpectedly push a patient into one of those higher risk categories?
Immune status is a massive factor. Conditions like blood cancers, HIV, or having a history of stem cell transplantation change the risk setting entirely. Patients absolutely must tell their treating clinician about transplant medicines or any chronic immune-modifying treatments. But here is my stern warning. Never, under any circumstances, change those immune-modifying medicines on your own. Any medication change requires careful coordination with your prescribing or transplant team to ensure you don't endanger a transplanted organ or underlying disease.
The evidence makes this incredibly clear.
Take a look at this pooled standardized incidence ratio, 45.87. Across 67 population-based studies, solid organ transplant recipients developed SCC roughly 46 times more often than the reference populations. The individual study estimates varied widely depending on organ type, regimen, and time since transplant, but the takeaway for patients is crystal clear. This group requires prevention, early assessment, and highly coordinated follow-up.
Beyond immune status, we must map out regional nerve and node symptoms. If a patient experiences new burning pain, numbness, tingling, unexplained weakness, or discovers a new firm lump in a nearby draining area, like the neck, armpit, or groin, this completely changes the urgency of the evaluation. Now, just to be clear, based on what we learned earlier, finding one of these symptoms or a lump doesn't definitively prove the cancer has spread on its own, right? It just means we need a prompt, risk-directed evaluation. A reactive lymph node and metastatic disease can both cause a lump. The symptom demands examination, but it doesn't prove perineural spread or metastasis all by itself.
Section 5. Treatment and next steps. With all of these complex risk categories, immune factors, and pathology details flying around, how does a patient move forward with this information to actually get treated?
Well, we match the clinical setting to the right treatment. For most localized invasive CSCC, surgery is the main treatment. Lower-risk localized tumors are often appropriately treated with standard excision. Depending on specific anatomy and tumor features, Mohs surgery or selected other local treatments might fit perfectly. But for higher or very high-risk localized CSCC, complete mapped margin assessment is favored. In those selected advanced situations, the plan may bring in imaging, radiation, systemic therapy, and multidisciplinary care.
So, for a patient heading into a prompt outpatient planning conversation, you need to verify the exact site and ask for a copy of the pathology report. Ask your doctor directly, is it in situ or invasive? What is the exact risk category based on the pathology? You should ensure you've named all your risk modifiers like prior radiation or immune medicines, and ask if nearby lymph nodes were examined. Finally, ask why the proposed treatment fits this specific risk and site, and exactly how the margins will be assessed.
This explainer provides general educational information, not individual medical advice. We invite you to read the complete evidence-based article at Skin Trust, review the exact references, and discuss your individual decisions with your treating clinician as your neutral next step.
Once you understand your exact diagnosis and risk category, what happens when you are ready to compare the specific surgical paths, like standard excision versus Mohs? We'll be tackling that in our next explainer.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Because when it comes to skin cancer, the most dangerous thing you can do is assume a spot is harmless without checking the boundaries. What is your skin telling you today?